Good morning, everybody. Welcome to our fall season of grand rounds. This is Jolene. And a couple of announcements in light of a lot of feedback that we've had. Can you hear me back there? Okay. It doesn't sound like it's working. Does anybody else sound like it's working? It's not working. The microphone. So I guess I'll have to be very careful this week. Very close to That's odd. Anyway, in light of this new technology, we actually are using a new web platform for our webinars starting this session. So people that are on the webinar, you should be hopefully seeing things a little differently, a little higher quality, as well as working with our videos and be able to hear more. So if you have feedback, please feel free to let us know that. That changes all the notices that you've been receiving and everything. It all comes through in the system. So we do welcome your feedback. In addition, on your way out, please speak with our sponsors this week, Titus and Novartis. And with that, I'm going to have Lisa Kendall make a little announcement.
Good morning. MHIF has really taken quite an initiative to increase awareness of our clinical research trial. And today, I don't know if you saw the slide that was up here today on ROADSTER 2. Dr. Titus will talk about it in addition. To that, we'll have another 2 studies coming your way, one of 3 ways actually. One is through this venue, through through grand rounds. The second is through email. And the third is through your section meeting. So Dr. Titus, again, will do ROADSTER 2. You'll also be seeing an email come from me this week, and I ask 3 things. Please don't delete my email. Don't delete me. The second is open up that email. Really great information, very succinct information. I'm not here to dribble on about studies, but give you the right information at the right time in order to increase the dialogue between patients and yourselves, because we all know that successful trials really involve you all, and we're looking forward to that. And then with that, I think I'll turn it over to Dr. Titus, and she will go over cutting out the middleman.
Can you hear me? Yeah. All right. So thank you for asking me to present, and it's a lot of pressure to kick off the fall season, so I'll try to do it justice. I think a lot of interest was generated in this trial after Dr. Alexander did his grand rounds, and so I'm kind of expanding upon that, and we'll really focus on ROADSTER 2 and the ROADSTER trials in general, and kind of what this technology involves and how it's panning out over time. So it's called Cutting Out the Middleman, the Transcervical Approach to Carotid Artery Stenting. So if you look at the history of carotid surgery, we've actually been doing different carotid procedures for quite some time, with actually the first ligation back in the 1800s. Stenting really came to fruition here in 1977 when the first percutaneous angioplasty was documented. DeBakey actually did it open in 1967, but after that, percutaneous took over, and then we've seen things expand since then. So why the rationale for minimally invasive approaches, and Jason kind of went over some of these in his presentation, but just to review, in general, we always try to make everything more minimally invasive because the purported benefits are shortened operative times, smaller incisions, decreased length of stay, and the surrogates for those are faster recovery, and then no need for general anesthesia. Well, if you look at carotid endarterectomy today, CEA times in this hospital are around 2 hours, which is a little bit longer than the reported for transfemoral stenting, but certainly not hugely increased. This is an incision of Dr. Sullivan, 2.5 centimeters, the mini carotid, and so making a smaller incision is near impossible. And average length of stay, we still keep the transfemoral stents overnight because the main issue is blood pressure and blood pressure concerns. So you really can't improve upon that because CEAs already only stay 1 day as well. And then the general anesthetic, it's been well documented that it's safe, it's effective, and it's actually good for the patients to do them awake in certain situations. And certainly Dr. Alden does probably about 40% of his awake. So I think the question is, why do you need anything but a carotid endarterectomy? It's a pretty good operation. It's really stood the test of time, and it still remains the gold standard. So why would we do anything else? When you look at the patients who come to us for carotid endarterectomies, not unusual, you'll see, to have people who have had a radical neck for one reason or another, people who have had significant radiation, also those with a high carotid, up around C2 in a surgically inaccessible area, and then those who have cardiac comorbidities, because as we'll see, one of the things with carotid endarts, as opposed to stenting, that routinely shows up is your risk of MI is higher. And so if you have a patient at a lot of risk from one of these anatomic or physiologic standpoints, you would prefer to not have to do an endart if it's not the best thing for them. So how did carotid stenting start? In 1977, as I said, the first percutaneous angioplasty was done. That went well. So then in 1994 at Stanford, actually 2 stents were placed for spontaneous dissection in patients who were not otherwise operative candidates. These were trauma-related, and both of the patients lived actually through the perioperative period. So they said, great, this is the wave of the future. And so 2 trials took over. The first one in 1993 involved 110 patients, and the end result, 11% stroke or TIA rate, which even the head people for the trial said is unacceptably high. And in order to continue, the adjustments needed to be made to offer this therapy to patients. In 1998, this was a European trial, 17 patients, only 17 because it was stopped after randomization of the 17 because 5 of the first 7 patients randomized to stents had neurologic events. So has that borne out over time? We've continued on with better techniques, distal embolic protection devices, which we'll go over a little bit. But if you look in every major trial that's been done, and this is really even borne out into a huge meta-analysis, stroke within 30 days continues to be higher for stenting in every trial. And if we look at MI, as I said, that's the downfall of endart. That's where carotid stenting beats endart in pretty much every trial as well. So when you look at the endpoint for a lot of these trials, it'll have stroke or death or MI as their primary endpoint, and they're all weighted evenly, which most people would argue who do carotid interventions is if you have a silent MI, that's not really a big deal. If you have a stroke that's debilitating, that's a huge deal and what we're aiming to prevent. And so they perhaps shouldn't be weighted evenly. But because if you look at the death rates, a little bit higher for carotid endart there, but otherwise pretty much equal for the 2. So really when you look at how the trial is borne out, stenting is always higher stroke, carotid endart is always higher MI. And so that's something to keep in consideration when you're looking at your patient and trying to decide what best therapy to offer them. The CREST is probably the most quoted carotid stenting versus endarterectomy trial, and that's because it was the largest randomized controlled and involved 108 U.S. centers as well as 9 Canadian centers. So huge studies, 2,500 patients were followed over 2.5 years. Both symptomatic and asymptomatic were included. And then it looked at 4-year rates of primary endpoint of stroke, MI, and death. So huge trial, pretty good endpoints, pretty well run, involved 477 surgeons as well as 224 interventionalists. And the good thing about this trial is it required previous experience and certification. So they didn't want a big learning curve involved because that was the critique of the early stenting trials was, well, these practitioners are just getting a handle on the technology. They've been doing endart for years. And so what we're seeing is really a learning curve. And so what they required a minimum of 12 procedures per year. And then you had to have complication and death rates that were less than 3% for asymptomatics and less than 5% for symptomatics to be included in the trial. So not only had to have done a bunch, you had to have done them well. The primary endpoints of CREST were any stroke, death, or MI in the peri-procedural period, and then if lateral stroke up to 4 years. So when you look at it, no big surprises here. It kind of showed what the rest of the trials show. Death rates were relatively similar. Stroke higher in stenting, MI higher in carotid. And so the composite endpoint was no different. And that's why the conclusion of the trial, if you read it, is that there's really no difference in the composite endpoint, which I think bore out a little bit different in the literature than we would like it to based on people's interpretations. So when you look at 4 years, that effect held out, so stroke still higher. So when you look at, and these are all clinical strokes, remember, so clinically significant symptoms, they didn't do investigations otherwise. When you look at silent strokes, I think the differences between stenting and Endart become even more profound. And I don't know about you, but if I'm going in for an intervention, I don't care if my stroke is silent or not. I'd just rather not have any new lesions in my brain. And so when you look at the ICSS data, when they looked at the DW MRIs, 50% of the patients in the stenting group had at least one new diffusion-weighted lesion, whereas 17% in the endarterectomy group. So that's pretty profoundly different. And was that just the ICSS trial? We'll see. But so the conclusion about three times higher risk of new lesions, silent or otherwise, associated with stenting. The Profi trial was looking at this trial and basically said, okay, that used a distal and pollock protection. So let's look at it with proximal balloon occlusion because then you don't have to cross the lesion, which is where they thought the strokes were coming from. And so they compared the two with DW-MRI after, and they found that actually the proximal occlusion balloon did a great job. It lessened it from 87% new lesions to 45%, which is truly concerning, I think, for both of them. And so what the capture registry data did is said, let's take all these strokes from stenting, let's try to figure out why they're happening, because we agree it could be a good technology, and perhaps if we change things or if we get better ways to protect the carotid circulation, that it will hold out and it will be a good therapy moving forward. And so what they did is they took the real-world study of the AccuLink AccuNet stent device and looked at the outcomes as it percolated into use. It ranged from October 2004 to 2006, 144 sites, 353 proceduralists, 3,500 patients. And this was a blinded, neurologically audited trial, which is good because neurologists who were not at all involved or served to gain from the trial were the ones doing the stroke evals. So they looked at the stroke timing, severity, locations, and type. So they really delved into where they were, what was happening. So 170 strokes happened in 168 patients. So overall a 4.8% rate, which is pretty similar to the national literature so far on stenting. 88% of them were ischemic as expected. Increased risk in octogenarians and symptomatics, which is no surprise. So everything kind of looks similar to what you would expect. And then ipsilateral in 82%. So almost 1 in 5 strokes were contralateral or posterior circulation. And so what that meant is a lot of the strokes weren't actually coming from crossing the lesion or that part of the intervention, but yet very likely from the arch or the origins of the vessels themselves. And so when you look at the different strokes, why are they happening? So first of all, protection devices, as I said earlier, these are most of the distal protection devices used. They involved a basket or a mesh of some sort to go up above the lesion you're treating and catch the debris. In order to do this, there's 2 problems with it. Number 1, you have to cross with a wire, and you're doing so unprotected in these situations. And number 2, you have to recapture. And so you can imagine if this gets completely filled with gunk, as we'll see in the filter for some of the TCARs we've done, you can imagine that recapturing this and pulling it through the stent would be somewhat concerning. So then they came up with the MoMA, and the MoMA is a protection device where you don't need to cross the lesion. And what happens is you get into the external carotid, and then this balloon goes up in the external so that you only have direct flow into the internal at that point. And then when you're ready to do your intervention and cross the lesion, you blow up your proximal balloon, and this sits in the common carotid. And then through this little side port here is where you put your wires, balloons, stents, and it kind of creates a pseudo flow reversal, much like we do in the OR. The idea is that the debris will come through this little port, and people aspirate and try to get it out that way. It did okay. It's very cumbersome to set up, and there's a lot of stopcocks associated with it, a lot of different aspiration ports. And so it was never widely used, and actually it doesn't have all that much different of a protection when you look at the distal embolic devices. And that's very likely because this side port is really not catching a lot of the debris. And so a lot of the debris is sitting on top of the balloon. When the balloon goes down, it goes up. Other ways, but really the problem with the interventions is looking at the arch disease, and especially tortuosity in your entire way. So when you're going through the femoral, you're dealing with iliac tortuosity, possibly aortic tortuosity, and then arch, as well as the vessel itself. And so by the time you get up there, a lot of times there's so much torque in the system that any little movement can cause a whip, and that's where you get a lot of your strokes from. And so you can imagine coming up on this arch would be really unfavorable, especially if you're going for the left carotid, and then when you look at disease in the arch, this would scare a lot of interventionalists. And then just even calcification, you can knock off those little pieces and they can go upstream, causing a stroke. So this is where the TCAR came from, and I think this is a very brilliant technology. It's a very brilliant idea, and it's so simple. And most things in medicine that are really great are actually very simple, very common sense. And so somebody finally said, hey, what if we eliminate the arch, eliminate the tortuosity factors, give ourselves direct access. We're surgeons, we can get right to the common carotid and do our intervention, from centimeters away rather than, feet away, which will give us much more control, which will eliminate all the arch concerns and save the benefits of stenting in general. Also, along with this is it facilitates a really easy flow reversal setup that's very effective. And so with this, you can do your intervention much more protected than you ever have been able to. And so this is a little animation that we'll go through quickly. Common carotid cut down, and you get around the proximal carotid. Some people put a purse string. I like to do it at the end. And then you access with the sheath. The wire actually goes into the external, and then you place the main sheath. It also requires venous access so that you can reverse your flow. We'll go through those a little bit more in depth. And then under the protection of flow reversal, you put in the stent, and that's a really large bore catheter there. It's an 8 French outer diameter sheath that is on active flow reversal when you're doing your intervention, and then actually passive when you're not, which we'll show here. And then the incision's closed. It's a nice small incision, which people like, but most people, when they're especially symptomatic, they don't care about the size of the incision necessarily. So it's an incision right above the clavicle. Here, as you see, the sheath is number 1 sitting in. It really only, and the special thing about this is we had to develop a special sheath that could sit just very small distance into the vessel. So this only goes in 2 centimeters. Sutured to the skin there, and then it's hooked up to this flow reversal here. The main working port is there, and then this is the connection to the venous system, which is an 8 French sheath as well. So what does it look like in the operating room? This is just to show you how easy the flow reversal setup is. Basically, you keep this facing up because the filter is in here. You connect it, turn the stopcock, let it filtrate up, go, go, go. And then you hook it up to the venous sheath there, turn the stopcock, and you are connected to flow reversal. And then that's where your high and low and your stop button is for when you're shooting angios. flow reversal, I think, is the important thing too. So this is before we have the common carotid clamp, and so there's still forward flow there. But in most people, I haven't seen one yet that doesn't have a passive flow reversal. And how we check that is we're going to take a clear syringe, and you're going to be looking, this tubing is going into the venous system right there. So we're going to turn the stopcock the opposite way, flush it so that this port turns clear, and then turn it back, and you can see the direction of flow is actually to the venous side. So this patient's already on passive flow reversal. So things are already coming through the filter rather than going upstream. So this was the ROADSTER 1 trial, which is the neuroprotection device approval trial to see, does it work, is it possible, transcervical under this neuroprotection. And so you look, they really looked at high-risk surgical patients. So average age was 73, with almost a third of their patients being over 80, which, if you remember, in every study that's been done so far, octogenarians do worse with stenting. And so it included some of the high-risk, a fair portion of the high-risk patients. It also included a fair share of females. This is one of the higher enrolling female studies. And we know that females tend to have more difficulty with carotid surgery and strokes in general. Symptomatic, again, about a quarter symptomatic. Half of them were done under local anesthesia, and then the other half under general. Average flow reversal time, because some people worry about while you're on the active flow reversal, is the brain robbed of flow? When we do open carotids, we do brainwave monitoring, or we do stump pressures to ensure that there's enough backflow. And so 10 minutes really is about the time, if you have a difficult time getting a shunt in, if you think about it, that's about the length of time your carotid is clamped anyhow. Acute device success, technical success, and procedural success were in the high 90s. So how did they do? Very well, actually. So there are no major strokes, not a single major stroke. There are 2 minor strokes. Both of these were in asymptomatic patients, so none of the symptomatics had a stroke. And of the minor strokes, one of these was adjudicated as the patient had intracranial disease, so they never should have been involved in the trial anyhow. But they had a minor stroke, which resolved. And so if you look at per protocol, the real stroke rate was 0.7%. And then deaths, there are 2 deaths. They were both unrelated to the procedure. One patient had a MI 15 days out from surgery after presenting with diabetic ketoacidosis and developed pneumonia. The other lady died in the, I think it was 14 days out from a prolonged stay from respiratory failure and pneumonia. You can see the MI there, and then the combined stroke and death rate. Cranial nerve injury, so there was one patient who had a temporary hoarseness of the vagal nerve, because that is the only nerve that's still at risk because it runs right with the carotid even down there. And that resolved by 6 months. So overall, very exciting results, very good outcomes. And then another neat thing that they did was they did diffusion-weighted MR in these patients. And so we can now compare it to the ICSS and the Prophy trial that I showed earlier. And when you look, they were performed post-procedure after them, and then again, independent blinded neuroradiologists read them. 5 patients had evidence of a new lesion, which is 16%, which, if you remember, carotid endarterectomy in the ICSS data was 17%. So overall, it's carotid endarterectomy-like rate of new lesions on the DWMR, and certainly better than anything that's been described for stenting in general before. So it looks like eliminating the arch along with the added protection of flow reversal really panned out. So then ROADSTER 2 came about, and this is the real-world application for the neural protection system, as well as approval for the en route transcarotid stent. And to make it a real world, it included physicians of varying experience and started enrolling in September 2015. Estimated end date is March of 2018. It involves symptomatics who are greater than 50%, And for ROADSTER 2, they added a level of risk and said for asymptomatics, we really want them to be greater than or equal to 80%, because this is what most vascular surgeons now are doing for asymptomatics. We're not intervening on a lot of 70%. Endpoints, primary is procedural success without major adverse event. Secondary, acute device success, technical success, looking at cranial nerve injuries, death from different reasons, and stroke. And then they sorted out by physician experience, training level, and the enrollment quartile. Inclusion criteria, so if you're looking at your patient in the office, they're pretty high risk and you're wondering if they're a candidate for TCAR, it's pretty straightforward. So for the logistics of it, it needs to be a 4 to 9 millimeter vessel. The common carotid has to be at least 5 millimeters in diameter to allow for placement of the stent system itself. And then the big thing is we need 5 centimeters to the carotid bifurcation from the clavicle, and that's related to the cut down and then being able to get the sheath in. We don't want the sheath sitting up at the bifurcation because you need to get that in before you go on flow reversal for your protection. And then this will come into play earlier, vessel access area and the common carotid free of disease, and you'll see what happens when that doesn't work out. Life expectancy greater than 3 years, which makes sense. They're doing a trial. They want long-term data. And then looking at surgically, so the patients still have to be high risk. So either by anatomic, being a contralateral occlusion, tandem stenosis greater than 70%, high lesion, restenosis, so reoperative field, and then closely staged carotids, and then hostile necks who have either had a prior radiation, prior operation, or have cervical spine immobility, or a permanent cranial nerve deficit on the contralateral side. Also, we look at clinically high-risk patients. Pretty easy to get into this category in the patients we see. Greater than 75 years of age will get you there. And then basically looking at their coronary risk factors and pulmonary disease, as well as chronic renal insufficiency. So when you do this procedure, you'll see we really don't use much dye. So we don't worry too much about those with some renal insufficiency. And the thing to remember is all the things that would eliminate you or make transfemoral stenting hazardous are allowed to be in this study because none of this really matters to us. Exclusion criteria, and this is where we ran into some problems, and we'll see that that another study was born out of this. So obviously they want to eliminate confounding factors for stroke in the trial. So they're going to eliminate any cardiac sources. So chronic AFib, proximal AFib within the past 6 months, or requiring chronic anticoagulation, known cardiac sources. So if they have a history of any of these, you'll see a prosthetic heart valve is on there. If they've had an echo that's clean in the last 6 months, then they're still a candidate for the study. So if you have a patient with a prosthetic valve who this is probably the best therapy for, we just get an echo, make sure they're clear of vegetations, and then they can be included in the study. Recently implanted heart valve, and again, looking at echo, as long as they've had an echo, and this hasn't been within 6 weeks of the planned procedure, then they're good to go for the study still. And then looking at intracranial circulation, so an AVM, a cerebral aneurysm, or intracranial stenosis greater than the lesion to be treated. So if you have a 90% MCA stenosis and a 70% internal carotid, you're not going to be a candidate for the study. So how are we doing? 40 sites, 600 patients is the goal, and we are now halfway through enrollment. You can see here with the stars on the different states involved so far. And the neat thing about being here in Minnesota is you see this whole area here that this technology is not available. And so we are getting some referrals from North Dakota, South Dakota. I think probably the Montana will go to Washington. But it's good novel therapy. Patients are actually calling in and asking for it or asking their physicians for it. And so when they look it up, we are the nearest site for a lot of these people without it available to them. Because of the issues with this really being the best therapy and sometimes the only treatment for certain patients that are eliminated from the trial because of atrial fibrillation, a lot of our patients have those cardiac comorbidities. And so if we can't include them, it was making a lot of people very frustrated. And so out of this was born the VQI registry, which is the Vascular Quality Initiative. It's the same one that does carotid stenting in general, but basically they put a TCAR surveillance study into it. And so patients who aren't enrollable in the trial are able to be treated under a trial protocol under this surveillance project. So our AFibers are patients with a history of cancer where the oncologist can't tell us they're going to live 3 years, but they're symptomatic. You're not going to let a patient with prostate cancer who may or may not live 3 years continue to stroke just because you can't get them in the trial. And then statin intolerance is another one of them. And so the VQI has allowed us to treat these patients appropriately with the correct therapy. So our Abbott experience so far, we'll go through a couple cases just to show, are we doing the easy ones? Are we doing the chip shots? Absolutely not. So this was one of our first ones, actually. 72-year-old female who came in with recurrent TIA. She actually presented to another hospital with her initial TIA and had been discharged there to go to Sister Kenny for rehab. When she was at Sister Kenny and doing physical therapy, it was noted that whenever her blood pressure went low, she would have recurrent symptoms. And these weren't like a little bit of numbness in the hand. They were dense hemiparesis on the right side, so quite frightening. And they tried to keep her blood pressure up because she was told she needed to wait for a procedure at the other hospital. And so they consulted us, and because they couldn't discharge her, knowing that she would continue to have flow-dependent TIAs. She had a history of a radical neck dissection followed by high-dose radiation for carotid cancer in the 1990s, and so this is not the modified radical neck. This is the full-on radical neck. You could actually walk in and see her carotid pulsating in the skin, which is nice because now we can see and feel our stent. She also had angio before with significant growing complications and was not at all interested in undergoing that again. So this is her lesion here. You can see some ulcerations, really narrow. So we took her and severely scarred neck actually all the way down. This is our procedure. You can see there's the lesion there. Nice distal, normal appearing distal internal carotid, and there's our completion. So at follow-up, she was discharged uneventfully on post-op day 1 with no further neurologic events. She did experience some temporary vocal weakness at home, but by her 1-month post-op visit, this had resolved. Her vagus was actually significantly scarred to the front of her carotid, so I expected that. I actually didn't expect it to resolve by 1 month and was pleasantly surprised by that. I continued to follow her. I last saw her in June at her 14-month follow-up visit, and her carotid remains wide open, and she is doing well with no neurologic events. The second case demonstrates another benefit of the TCAR. It's a 68-year-old male who presented with angina. He was found to have severe true vessel disease, and they recommended CABG as opposed to PCI. Incidental finding at that time of right ICA occlusion and a left 90% stenosis. So the discussion was, should he have a carotid intervention, or should they proceed with CABG? He also had a left subclavian occlusion, so the vert on the left was out, the right ICA was out, the left carotid was 90%, and so the only thing really filling the brain with any gusto was the right vert. He also had a 2009 supraglottic laryngeal resection and tracheostomy for cancer. His tracheostomy was obviously closed at this time, and as I said, the left subclavian occlusion. And so this is where some teamwork took place in discussions between cardiac surgery, ourselves, and the cardiologist, and we decided to proceed with TCAR. Now remember, with the trial, you need to have at least 6 weeks before any intervention. They felt they could adequately medically manage his coronary disease until that time, and just really felt that stenting him was the wrong way to go. And so we did the TCAR. You can see here the lesion's heavily calcified, and I couldn't get a good view with the actual lesion itself. And you can see here kind of calcium all around it with a little sliver of flow between them. And then that's an ulcerative area with a little flow outside of that. And you can see here from another projection with the ECA filling. And then that's our completion. So he did well. Was discharged with no neurologic events. He returned 3 months post-operatively, and we put in a left subclavian stent, and the next day he underwent a 3-vessel CAB and did well from that. He was last seen 4 months out from his TCAR, still doing well. Duplex showed a widely patent carotid. So at the end of the procedure, if you remember, the box thing in it is the filter. We always cut the filter open at the end because it's fun to see what we've caught, and we take pictures because the patients actually like to see what could have gone to their brain. And so this is one of the filters we've cut open. You can see a lot of times we just see these little specks like in the background there, but this had really a lot of debris in it. And this is another different one where we caught a fair amount of debris. So you can see from the size of the particles, the flow reversal is actually quite effective. So with any new technology comes new unique complications specifically related to that technology. This isn't new or independent of access in general. We know in the femorals you can get dissections at those access sites. Same thing here, and actually what we found is when we do fatter patients with these real thick necks, you lose a lot of space from your clavicle because you have 7 centimeters and now all of a sudden, to your bifurcation you have 5 because they're so deep. And so we really try to get back towards the clavicle more and mobilize as much as we can, but then your angle of access becomes really awkward. And so what they found, actually, there is a 2% rate of common carotid dissection requiring treatment in the ROADSTER 1 trial. And that difficulty has continued on, especially as we're liberalizing the therapy. And so actually we have had one of these here, which I think is we dealt with it very well. It involved some troubleshooting as well as some sphincter control at that time. But we got the sheath in, and our micropuncture went up, and this is what we saw. And nothing filled above there. And so our heart stopped for a bit, and then we continued on. The reason for this patient was a high lesion, and you can see here he's all the way up at C2, well above the angle of the jaw. And so surgery would be quite difficult access-wise. Oh, it doesn't want to work anymore. There we go. And so we took him to the OR. This is what we saw. And so we pulled this is a TEG catheter as we were trying to get into the internal. And we kind of knew because our micro wire just was folding up in a funny way. And so we suspected a dissection. We actually said, well, is our sheath in a dissection? So we pulled everything out and just shot through the sheath alone. And you could see our sheath itself wasn't in the dissection, but the entry tear was kind of directly below it and extending up. And so we tried different wires, different ways, and it ultimately ended up pulling out the sheath, repairing that area, and doing another access just below that to get into a fresh area. And then when we shot from there, there's a little spasm of the internal. That's the main lesion. But you can see the dissection's there, but it's no longer filling. So what we did is we stented, and then we added another stent down into the common to cover the entry tear. The patient actually did quite well. It was discharged with no neurologic events. His stent continues to be open, and his post-op ultrasound actually didn't even see any element of dissection. When you look back, and actually this is why he was eliminated from the trial. And when we took him out of the trial and put him in the VQI, we kind of poo-pooed it and said, okay, great, whatever, sure. And of course, that's the patient it happens on. But this is the culprit, is that single piece of calcium. And actually, as most of us know, that when there's a little piece, there's usually more when you're there in person. And so it's down here, though, kind of right in, the sheath will go in here, and then 2 centimeters point that's where the end of the sheath sits. And so I think when the end of the sheath sat there, it probably sat against the back wall, and then the wire just kept going into the dissection plane. So how are we doing? We've performed 20 so far. 11 have been enrolled in the study, 9 in VQI. And the VQI ones, remember, are extremely high risk. I think we've done an 88-year-old is our oldest, and lots of comorbidities. 100% technical and procedural success. Anesthesia, we're not at 50-50, but I think we're starting to get more used to the procedure, and we're doing more of them under local. But right now we're 80-20 as far as general versus local. Operative times, our average is 77 minutes with a range of 52 to 103. Our flow reversal times, 12 minutes, high of 33. That was probably our dissection case. And then a low of 5, which I think this is driving up our average. But if you look compared to the nation, we're actually still on the lower side of flow reversal times. And then if you look at ROADSTER 1 plus ROADSTER 2, they're averaging around 10 minutes. Contrast usage, about 24 cc's. So like I said, most of these procedures are around 10, 12. You know, when we get into difficulty, that's where the 50 came from. But most are around the 10 to 15 mark. So it's not overly burdensome on the kidneys. If you look at nationwide, we're below the usage of contrast. I think it's because some people at the end do a full formal cerebral angiogram with completion on both sides. We haven't found that to be necessary. Fluoro time, average is 7 minutes, with our low end being 2.5 minutes. And nationwide average is 5 minutes. Again, I think the dissection case is bumping us up there. But overall, no deaths, no strokes, no MIs, and no major adverse events. So I think we're pretty proud of our outcomes so far. We're interested in doing more cases. We're excited about the technology. And I think this is something down the road is we're going to say, how did we ever do it any other way? Because I just think it's a good system. It provides good protection and all the benefits of stenting without the risk that you would hope to avoid as far as the arch and the origin of the vessels go. So I'd like to throw a special thanks out to Joanne Goldman. She's been such a great champion of this study and is always super positive and has been a great resource for the patients. They love her, they trust her, and she's been exceptional. So, questions?
Fantastic. Thank you. Do you know what the incidence or in neuroradiology patients are getting alternative kind of therapies like that, and can you protect at surgery as well?
So what do you? So for neuroradiologists, how many stents are they putting? So they can't do this procedure, and so unless they're teamed with a surgeon. I don't know how many stents they're doing here. I can tell you the far majority is being done at this hospital, at least by us, other than in the acute occlusion cases, and we're working with them actually on those and kind of making that decision together a lot of times whether to stent or not. But they're not doing a lot of independent stenting, and that's because a lot of the referrals are directed, at least in this hospital, to vascular surgery. Nationwide, I think definitely neuroradiologists are doing more of the percentage, and I don't know what exactly that percent is right now. The second question is, do you... In open surgery, we've talked about it actually and kind of propagating to when you have a carotid with thrombus sitting there and the patient's symptomatic, we always juggle what to do. Do you anticoagulate? Do you do a carotid with a no-touch technique where you don't even get around the internal, you just get around the common and the external and then open it up and hope it back bleeds out? We actually discussed, you know, is this a potential use for this to stick in the flow reversal, suck out all the clot under active flow reversal? But no, it hasn't been used in open surgery yet. But I think that with the flow reversal technology, I think that may be an area to expand on.
Has it been used the technology for Has anyone used the technology for acute MCA strokes? So what our neuro-IR guys are currently doing with their transfemoral approaches?
So I talked to Dr. Kyan about that, and he said, we don't really need it because if we send something up, we just go capture it anyhow. So I think they're used to sending stuff up into the brain, whereas we're really not. And I think, they have the tools and stuff to go get it. I think if they worked with the technology and stuff, that's where I think it has a good role in acute strokes. But that would mean actually taking an acute stroke to the OR, doing the common carotid cut down, which the common cut down takes all of about 10 minutes. On the deeper necks, it obviously takes a little bit longer, but it's right between the heads of the sternocleidomastoid. It's not a hard area to get to. It's not a hard area to numb up. The patients, we inject maybe 10 a local, and they're fine throughout the case. But yeah, I think in acute strokes, if we work more with the neuro radiologist, I think it'll be a good, because you'd rather not than that, because some of it has to shower is my point. But
a great talk, wonderful, a lot of learning points here. Was there any difference between the population that had a general versus the local anesthesia in terms of outcomes, especially MI? And then was there any complication in the femoral vein side, like if you have a DVT
or hematoma or anything like that?
So in ROADSTER 1, there was one femoral vein access hematoma. It was treated non-operatively. And then what was the first question again?
So
they're different in terms of outcome between the population that had the general versus the local anesthesia. Were there any more out?
It's hard to make conclusions based off of the data because there was only one MI in the ROADSTER 1. That patient did have a general, but remember it was 15 days out when he had an episode of DKA. He returned and had an MI then. So I don't think they blamed it on the procedure. I don't think they blamed it on the general anesthetic. But certainly you would think if you don't have to have general anesthesia, because we think that's where some of the carotid MIs probably come from. And so if we can do it awake and under local, I think that's the goal, is to get more and more of these. The most recent one that we did, the ball was kind of already rolling for him to be local. He was about 350 pounds, had obstructive sleep apnea, and it was a nightmare. But for both us and the anesthesiologist, but we got him through it, and actually, I mean, it went fine. It was just taxing on us. And so I think we did the most difficult patient we could awake, and so I think we have room to expand on those. And I think if you have good anesthesia who's, somewhat calming and can talk them through it, I think it's better to do them awake. Plus, it's nice for us because if we're worried at any point, you just tell them to squeeze there's a little squeezy toy, and you just got to remember to tell them to squeeze the right hand, because I always ask them to do the wrong hand, and then they don't. Then no noise comes, and I freak out. And the one patient actually reminded me that she should be squeezing the other hand. So.
Thanks, that's a great talk. 2 questions. When you do TCARs, do you have the neuromonitoring devices on? And so do you intraoperatively monitor them the same way as your carotids? And the second question is there I don't know, intermediate or low risk trial patient coming after this?
So the first question, we did neuromonitoring on one case. And it's a lot of setup for basically what you're trying to decide in the OR when you're doing the neuromonitoring is, do they tolerate clamping? And so in this situation, the question is, are they tolerating flow reversal? The vast majority of patients will tolerate flow reversal just fine, and so we decided it's kind of a setup. And then what are you going to do if they don't? You're just going to get it in quick, right? Because that's what you do open is if you're clamped and they're not tolerating it, you get the shunt in quick, and then you're fine. No. And it's a lot more awkward logistically than it really needs to be for very little benefit in these patients. And especially if you're doing them awake, then you're going to know. And then the lower intermediate risk, I think that's coming down the pipe. The thing is, the holdup is Medicare and all of the billing agencies won't cover these outside of a trial because carotid stenting has been shown in every trial so far to have a higher risk of stroke, and so most people won't approve them. So I think with the ROADSTER 2 data, if it looks as good as the ROADSTER 1, potentially we'll see it more available. But I think it's probably always going to be, because carotid endarterectomy is such a good operation, I think it's going to continue to be kind of reserved for those that are high risk. Did you have a question?
Well, I was going to expand on something that Nita mentioned, and we probably just need to all be aware of here, is that all of these trials that look at percutaneous stenting from the femoral artery versus carotid endarterectomy, they tend to look at MI versus stroke, but they're really looking at silent MI versus stroke, and that's not a fair comparison. So what we really need to be looking at is silent strokes versus silent MI. And if you were to look at that comparison, there's a dramatic difference between the two, because you're talking about a 40 to 70% silent hit rate from percutaneous femoral stenting versus carotid endarterectomy, which has a much, much lower rate. So it all depends upon what you're looking at. And that's where TCAR is a huge advantage, and why, when it comes down to it, when you look at different practitioners evaluating interventions for stroke, you honestly have a group that's trying to decrease the stroke rate, and there's a group that's trying to put in stents. And you need to be very careful about that. Okay? Just my final comment on the TCAR. The TCAR is probably the first procedure other than carotid endarterectomy that legitimately has a chance of carotid endarterectomy. And as a surgeon, we love it because the specific indications are often those cases that we fear the most as an open practice. We want patients to get a TCAR because we don't want to go to the high neck or into the hostile neck.
Yeah.
Here, shall we totally agree?
Yeah, I think a TCAR is a nice way to get you out of a difficult carotid, in a safe way.
This is a placebo microphone, I've learned. So. Thank you for enlightening us. Now, a question to you. In your opinion, how much of the reduction in stroke is the flow reversal versus avoiding the arch? Do you have any opinion about that?
I'd say it's probably about 50-50. Because if you look at the stuff we're pulling out of there, on some cases, on a lot of cases, it's little distals and not much to write home about. And in those cases, you probably could have gone transfemoral as far as with a protection device and been okay. But I think that what's hitting them there is the arch, And so I think if you look at the silent hit rate, of 40 to 70%, I mean, I think they're getting, when you're going transfemoral, I think you're getting some from the arch, you're getting some from the carotid. I think you're kind of getting it from both areas in order to have that high of a rate. And remember, 1 in 5 are, contralateral posterior. So if you take that and say about 20% are from the arch, then 80% are from you crossing the lesion. But I think probably, it's probably more towards crossing and the flow reversal protection. But I wouldn't say much. I'd 50-50 or, at best 70-30. So
when is the percutaneous technology coming so other specialties can see it?
We look forward to the carotid pseudoaneurysm emergency consults from that. Thank you, everyone. Thank you. Yeah. Bye. Yeah.
Unless you want to
Oh,
all day.
yes. No, I do not. How did it work? Good, good. We're fine. Just the slide clicker didn't work. Right, even though